Hello, I'm Courtney House, and today I'm going to be reciting an informative speech on a case study that was published in 2002. The case study starts out about a 3-day-old infant male who stopped nursing, has become jittery in all 4 limbs, and is also hypothermic. According to the case study, the patient was perfectly fine until this 3rd day, when the father noticed the baby had noisy breathing and was grunting every time he was trying to breathe. Now, the baby was born at 37 weeks of gestation, which is considered full term. There were no complications during the pregnancy, and there was also no complications in the cesarean section. Not really knowing what was wrong, the physician was called into the room to do a physical examination. The physical examination showed that the baby had severe hypertonia. Hypertonia is a condition where there's too much muscle tone in the body, which makes it very hard for the baby to move its arms and legs. So the doctor figured that's where the jitteriness came from. But he still wasn't sure on why the baby was grunting and had a wet kind of breathing noise, or why it had stopped feeding all of a sudden. So the neonatal transport team was called, and they were going to transport the baby to the neonatal intensive care unit, which is the NICU. Once the neonatal transport team had gotten there, the baby's oxygen levels had dropped down to 70% and it had to be put on oxygen. The neonatal transport team reported that the baby was transported with no further difficulty, so that's good. But once the baby did arrive in the NICU, they found that there was blood in the stomach and it had to be suctioned out. They took an arterial blood gas sample out of that, and they found that there were high levels of ammonia in the baby's blood. They figured out that the baby had also suffered from a severe pulmonary hemorrhage, which is blood in the lungs, and so then the baby had to be placed on a ventilator so they can get that blood out and so the baby can breathe. As more things add up being wrong with the baby, the neonatal team decided to run more tests to figure out why this baby that was perfectly fine is now having to be on a ventilator and has these high amounts of ammonia in its blood. The first thing the team turns to is hyperammonia. Early symptoms of hyperammonia include lethargic, poor feeding, and respiratory distress, which this patient was showing all of that. Hyperammonia is a metabolic disorder due to an excess amount of ammonia in the blood. Ammonia is a substance that contains nitrogen. Now, nitrogen in the body is processed by the urea cycle and is turned into urea that's contained in the liver. In the urea cycle, if it isn't working properly and this nitrogen stays in the body, it will cause death and a brain disorder. So the team needs to work fast to try to figure out what was wrong with this patient. Now, since the patient had a wet cough and was showing respiratory distress, more tests needed to be run, especially when an infant is showing these respiratory distresses. That is not good. So the first step to coming up with a diagnosis is blood work. Since there were no signs of infection in the baby, the physician decided to add plasma ammonia level to the blood. This would show if the baby would hyperammonia or not. So if the ammonia levels in this blood sample were to progress, then it would prove that the baby did have hyperammonia, which it did. Once the hyperammonia was established, further testing was done to get a more specific diagnosis. Liver function tests should be done to make sure there isn't anything wrong with the urea cycle, since its job in the body is to process nitrogen. Genetic analysis testing can also be done because all disorders of ammonia metabolism are a recessive trait, and they are on the X link. After running all these tests, the patient proved to have organochronic aciduria, which is a big word for a genetic disorder that causes ammonia to build up in the blood due to an enzyme deficiency in the urea cycle. An enzyme deficiency is when one of the 5 proteins in the urea cycle don't work anymore, or just don't work or function as properly as they should. Currently, there is no permanent fix to this disorder except for a liver transplant, but the patient can do maintenance therapy. Maintenance therapy includes a protein-restricted diet to avoid excess amounts of protein to build up outside of the organs, because the urea cycle can't break down that protein and turn it to urea, that it just stays outside of the organ. Physical therapy, occupational therapy, and speech therapy should also be involved, as long as a psychiatrist and genetic counseling. Hyperammonia episodes can still occur even though the patient does do maintenance therapy, and that should really be watched for, especially in a patient that has a urea cycle defect like this one. If they show any of the symptoms such as vomiting, lethargic, or disorientation, then ammonia levels should be checked in the blood. And if they are 3 times higher than the normal level, which is 50, then the child needs to be hospitalized and treated. Sadly, without a liver transplant, most patients with a urea cycle defect don't live into adulthood. But since this diagnosis was caught early, this patient should be able to easier manage their disorder, and this will also help minimize their chance of getting lupus, which is an immune disorder.